The American Journal of Obstetrics and Gynecology presents the etiology of preeclampsia. Preeclampsia is a syndrome defined by the presence of hypertension and proteinuria, which can have multiple causes or etiologies. Multiple pathologic processes can cause preeclampsia. These include uteroplacental ischemia, bacterial infection, SARS-CoV-2 infection, maternal intestinal dysbiosis, diabetes and maternal obesity, sleep disorders, hydatidiform mole, fetal diseases, autoimmune disorders, placental aging, immune dysfunction, and endocrine disorders. Of these, uteroplacental ischemia is the principal mechanism involved in the pathogenesis of preeclampsia. What is the evidence that uteroplacental ischemia causes preeclampsia? In 1914, Dr. James Young in Scotland proposed that eclampsia was related to the placenta. He reported that placental infarctions were frequently observed in women with eclampsia, as illustrated in the figure, and that these infarctions were the result of uterine ischemia. Young also showed that the administration of placental extracts into guinea pigs could induce convulsions, hepatic necrosis, and renal lesions, suggesting that toxins or poisons produced by the placenta will enter the maternal circulation and cause eclampsia. Young's hypothesis was strengthened by subsequent experimental studies. Ogden, Hildebrand, and Page described one of the earliest reports of experimental uteroplacental ischemia in pregnant animals. In the Goldblatt model of renovascular hypertension, clamping the renal artery leads to renal ischemia. The ischemic kidney secretes renin, which leads to the development of hypertension. By contrast, clamping the aorta below the renal arteries to induce uterine ischemia does not induce hypertension in non-pregnant animals. In pregnant animals, clamping of the aorta below the renal arteries reduces uteroplacental perfusion. Uterine ischemia causes hypertension. However, after the hysterectomy, clamping of the aorta below the renal arteries can no longer elicit hypertension. This suggests that the source of the signals leading to maternal systemic hypertension is the gravid uterus. Subsequent studies support the view that placental ischemia, rather than uterine ischemia, plays a key role in preeclampsia. The Z sutures are placed in the placenta to generate placental ischemia. The pale portion of the placenta after Z sutures represents a large infarction as shown here. Placental ischemia causes hypertension. A rabbit underwent laparotomy. Both kidneys are removed to obliterate the renal components of hypertension, and then Z sutures were placed through several placentas. Afterwards, hypertension developed as shown in the graph. What causes systemic hypertension? They proposed that an ischemic placenta caused by the Z suture releases toxins. These circulating toxins are responsible for systemic hypertension. To demonstrate the existence of circulating toxins, blood was collected from a pregnant rabbit with placental ischemia and then transfused to a non-pregnant rabbit. Transfusions of blood from a pregnant rabbit with placental ischemia to a non-pregnant rabbit caused hypertension. This study concludes that an ischemic placenta caused by the Z suture releases toxins, and that these circulating toxins are responsible for systemic hypertension. What about in humans? The first evidence that uteroplacental blood flow was decreased in preeclampsia came from studies performed in England in which maternal blood flow was evaluated in normal patients and in those with preeclampsia. This is the device used to measure placental blood flow. Blood flow determination was calculated by studying the disappearance of radioactive sodium that was administered into the maternal circulation. The mean maternal placental blood flow was 600 milliliters per minute in normal pregnancy, but only 240 milliliters per minute in patients with preeclampsia. What is the cause of placental ischemia in women with preeclampsia? The placental bed contains the spiral arteries that supply oxygenated maternal blood to the placenta. The decreased blood flow to the placenta is thought to be due to defective remodeling of the spiral arteries, which are the branches of the uterine arteries that supply the intervillous space of the placenta. Non-transformed spiral arteries can develop placental lesions of acute atherosis. Atheromas are the materials that contain yellow fatty substances in the vessels. When an atheroma accumulates within the wall of the coronary artery, it blocks blood flow to the heart muscle, leading to myocardial infarction. Similarly, this atheroma can occur in the spiral arteries, block blood flow to the placenta, and lead to a placental infarction. This figure shows the placental lesion of acute atherosis of the spiral arteries with lipid-laden macrophages. This figure shows fat droplets in the non-transformed spiral arteries. The role of uteroplacental ischemia in the pathogenesis of preeclampsia is well established on the basis of a solid body of clinical and experimental evidence. The next video will cover other etiologic factors in preeclampsia. This work comes from the Perinatology Research Branch of NICHD, the National Institutes of Health, and Wayne State University.